on to our next speaker, Dr. Mallikarjunan, who is a senior consultant cataract, cornea, and refractive surgery from Shankara Eye Hospital, Shimoga. Again, he is a surgeon of great skills with a lot of presence in the state and national conferences. He is a member scientific committee of Karnataka State Ophthalmic Society and the General Secretary of Mallanad Ophthalmologist Association. And he is going to talk to us on something very relevant, nuclear fracture and its relevance. On to you, Doctor.
At the outset, I would like to thank Chairman ARC, AIOS, Dr. Chitra Madam, and all the members of ARC for this opportunity. I'll start with the technique of doing a nuclear fracture, and I have made with the intention of showing it to a beginners. See, this is just around the 4 millimeter peritomy, and I am marking with a 5 mm caliper and just a 5 millimeter mark there on the sclera, and a 5 millimeter scleral incision, straight one, and it is a temporal side. And there is no need to use a cautery also. It needs little bit experience, and you can stop using cautery also. And you make a tunnel at one side full, and this is what I do, and it is easier. And just you can dissect the scleral fiber and complete the tunnel. And also it is very important to extend at the inner side both sides, something like it is like a trapezoid side, because we are removing the nucleus fragments in a very small section, and it is better to do a extend at the periphery. And as usual, rexis, and it is little bit larger than your phaco rexis, and the extension of the tunnel. It's very important to extend the whole of the tunnel and not to cut at the posterior lip. So tunnel has to be like tunnel. It has a four walls and a gentle hydrodissection there. And it is always better to do the gentle hydrodissection and rotate the nucleus, because this is what I do, because the safety is better when you rotate the nucleus, because it has to come out of the bag, and if it is rotating and easily it would come out of the bag, the nucleus. And now it is in the entry chamber. Put a viscoelastic, just it is a HPMC and no other viscoelastic put, and vectis, this is a modified vectis. It is maximum width is 3 mm, and dialer, the tip is straightened. And it has to be in the center. The victus has to be in the central. I'm using dialer. I'm not actually pressing it, not only pressing it, and making a rotatory movement there, so that the nucleus will divide into two pieces. So remove you can take out the one piece first, and the remaining one half is again it is placed in the center, because the nucleus has to come through the tunnel, so it has to go the direction of the pulling should be same as the direction of the tunnel. And you can then do the cortex wash. And the advantage of this is you can use a foldable IOL. So and the care should be taken not to press the posterior lip, so that it would be a closed chamber surgery. This is a one more surgery. Because of I think a shortage of time, I will directly go to the nucleus fracture. See, hydrodissection has been done, and the nucleus is prolapsed into the antechamber. It is, again, I'm repeating, it is important to put the viscoelastic on the nucleus and below the nucleus before you do the fracture. Again, the modified vectis, and it's it has to be in the center. Otherwise, what happens if it is a periphery? When you press it, the one side of the nucleus will move up, and it might injure the endothelium. So if you are in the center, definitely it would not touch the endothelium, even at the center or at the periphery. Again, the nucleus is one part of the nucleus is removed, and in the same way, the other part of the nucleus is brought in at the center, and it is taken out. So what are the other methods? These methods I'm not doing just for the completion's sake. I'm talking about it. There is one more snare method where there is snare-like thing which you can engage the nucleus in the snare and crush it into 2 pieces or 4 pieces and make it out. And there is some persons are doing intratunnel fracture, because I don't know, because I don't do this procedure. I'm not going to talk about this. And what is the relevance? Because it's when you make a small section, it's a closed chamber surgery. So we all know the advantages of closed chamber surgery. There is less chances of the end-to-chamber fluctuation, less chances of PCR and other problems, and there will be very less surgically induced astigmatism because of a small incision, and if you are doing at the temporal section. And when you have a PC rent or general dialysis, it is because of a closed chamber. It will be a very easy to manage doing the enterovictectomy and putting implanting the IOL would be helpful. And if you have noticed, there is no need to do any side port unless you have a very large subincisional cortex which is not coming. You can put a side port. And because of small peritomy, the closure of the wound is very faster, and patient can be rehabilitated very early. And this thing, I will put it to all the panels, because India has so many cataracts, and there is a lot of backlog of cataract. At least for the beginner or who has learned surgery, when he starts his practice, or whether he can just avoid buying phacoemulsification and start doing this phaco-fracture, and which gives as good results as phacoemulsification. This thought I would give open to all the panelists. And one more thing comes to our mind is whether the endothelium will be protected or not. See, these are all the picture of a post-operative taken immediately within 4 hours and within one day. See, you can see almost all patients are clear. If you learn this technique, the endothelial damage will be minimal or no endothelial damage. Thank you very much.
Thank you very much. Satyajit, would you want to take a question? Satyajit, are you there?
Yes, ma'am.
Yes. Yes.
My only issue was that when we are using this, we are bringing it into the anterior chamber.
Yes.
Would it not hurt the endothelium? And would it be more helpful using a thicker viscoelastic in these kind of surgeries rather than the regular HPMC? Would that help in protecting the endothelium?
Definitely that would come to everybody's mind, because if you can use something like a viscoat or viscoat-like material which are available in India, at the beginning you can use it, but once you become a little bit experienced, and you can use the HPMC only. You just HPMC, it will nicely coat the endothelium, and your endothelium can be clear. I mean, cornea can be clear later.
Dr. Deepak, when we talk about fracture technique, in the bag or versus AC fracture, anterior chamber, so what are the for and against on this? Can you unmute yourself?
I think both of them have got a distinct advantage versus in the anterior chamber fracture technique is extremely ideal for most situations. Including where the zonules are weak and where the bag is compromised. However, when the corneal endothelium is slightly compromised, we're dealing with a lesser count cell. In those situations, maybe fracturing the nucleus in the anterior chamber might not be the best option. For me, if the bag is healthy and zonules are healthy, in the bag fracture is the most safest way to break this nucleus. That is my preferred method when I'm doing manospontaneous cataract surgery. However, in cases where in Morgangian cataract, where the zonules are weak, that time I don't want to meddle anything inside the bag, just prolapse the nucleus out into the antechamber and then fracture it. So
Yes.
there are two distinct, advantages in each of the places. Thank you.
Now we know there is a loop or snare or bisectors being used. So either Dr. Ravindra or Debashish, one of you all could tell me which one is what you would suggest as the early steps for a surgeon, and what extra precaution to be taken when you're using a loop, when you would use it, when you would not use it.
Rahul sir wanted to make a point, but he is muted.
Yes, Dr. Sahu, we would like to hear your thoughts too.
He's muted.
What I saw that I have tried this method of dividing with the dialer, but I think it's a risky proposition, and because maybe in an experienced hand you can get away with some, but it is not the right way to divide the nucleus. The moment you put the rectus behind the lens, all viscoelastics comes out. And if you are having a high viscous there, totally the ball, it will come out. So what we are dividing the nucleus, continuously infusing this viscoelastic and then dividing, then the chamber is maintained. That point I wanted to add.
Yes.
Second thing, we are now dividing the nucleus in the bag. Megur is doing, I am doing, so many other people will be doing now. So there is no difficulty in dividing the nucleus in the bag. So snare, of course, is the Indian origin, so we can use it. There is no there is no room for my loop and all sort of things. There is no need for that. Our loop, the snare is as good as that my loop. And now that we are dividing the nucleus in the bag, so there is no need for it. We can do it a 2 millimeter incision. I take out the nucleus. So phaco, I think we should have a comparative comparison surgery.
Yes.
Yeah, let us have a comparison all India level with your initiative. Top surgeons, we will do side by side and see evaluate the results afterwards. I think that will be a time has come for us to really think that the SICS has come up age, and it is absolutely, result is unbeatable. So I think you can take an initiative to call few surgeons and let them simultaneously operate, and let us compare results.
Just my doubt. See, when you compare the antechamber fracture and intra-bag fracture, the intra-bag fracture learning technique learning curve is a little bit more, and that is what I believe, because you have to be careful.
That is see, it requires a pretty experience. It should be very experienced to get into the bag and divide it there. Not for the beginners, but this is, we are doing it now regularly. We are doing it. I saw this. Deepak is also doing a good job.
That's a take-home plan.
I'm doing all my cases in the
very experienced,
most of the cases,
not for the beginners.
80 to 90% cases I'm dividing in the bag, so
Yeah.
there is no problem.
I would like to
also understand if it is a hard cataract which has less epinucleus protection, are those cases where you would not want to do in the bag, like Dr. Deepak had said, hypermature cataract, of course, but in cataract with less epinucleus, would you want to do it in the bag?
No. Very hard cataracts you should not try.
Yes.
No, I would like to ask Dr. MSR. I think he does all the cases. Any cases you take, he does in the, he fractures it. Sir, would you like to?
Yes, Dr. Ramcha.
Yeah, this is I call it as phacosuction, and phacofracture is a nice terminology for that. Phacosuction is not invented by me. It's an American doctor who invented it. Had, it had the award, one of the best 10 ophthalmic surgeries. That's the award that was given to it. I modified Moore's technique. So the only one thing I would like to add is, as Dr. Amulya Sahu mentioned, I continuously inject viscoelastic in front of the nucleus with a 25 gauge cannula. That's the commercially available. I used to make it 26 earlier. Now I switched over to 25. Most of the cataracts can be bisected with just the shaft of the cannula itself. You don't need a tip or whatever it is. If it is not bisectable, then I use the cystitome that's already on the table to do it. But cystitome is again infusing visco continuously in front of it. Now the question came, which is the best visco that's conducive for the for this technique. I wouldn't say cohesive viscos are good at it, because cohesive visco do not protect the endothelium as much as dispersive visco. And cohesive visco will come out. It is an open chamber technique. Cohesive visco basically has not much place. It has place in specific issues, but not much place in an open chamber technique like SICS. It comes out. The moment you go inside, it's visco is out. So I would personally prefer either a chondroitin sulfate, which is a dispersive, or HPMC, which is affordable and excellent dispersive. And that's the one which you should be injecting through cannula in front of the nucleus to separate moving nucleus from the endothelium.
Yeah.
Yes. Thank you.